Okay, good.
Everyone chipped in immediately, which was.
Thank you for coming back to talk about provider taxes. I think we spent like a little bit of time on this, maybe the first 2 weeks of the session or something like that. It is not very clear in my memory, and I wonder perhaps that might be true for other members of the committee. So I'm glad that you've brought a little bit of a refresher with you.
Yes. Put it up on yours.
Refreshing might be good.
Thank you. Look at that.
We even have the date.
Yes, that's when we came in.
Yeah. Floor is yours.
Great. For the record, Nolan Langwell, the Joint Fiscal Office.
And Jen Carby, Legislative Counsel.
So today we're going to cover a few things. We'll do a quick overview of the provider tax. There'll be some discussion about I'll start with that.
All right.
The chair decide where to go from there. So provider taxes have long been associated with Medicaid funding, not just in our state, but across the country. The most recent 50-state survey was conducted by Kaiser Family Foundation. And they found that in 2003, there were 21 states had at least one provider tax. By 2023, 49 states and the District of Columbia had at least one healthcare provider taxes. The most common type of provider tax that is used by states are nursing homes, hospitals, and intermediate care facilities, which we used to have provider tax for them, but now we don't have any more intermediate care facilities. So we don't have a provider tax on them.
There are 19 classes of healthcare services that the federal law allows states to tax to generate revenue for the state share of the Medicaid match. And so you can see on here, Nolan has highlighted all of the ones in red with a star that are currently assessed in Vermont, and the rest are not. So we do inpatient hospital services, outpatient hospital services, nursing facility services. We had the one on services of intermediate care facilities. These are intermediate care facilities for individuals with developmental disabilities, but as Nolan said, we don't have any of those. Home health care services, although I think you're allowing that to sunset, outpatient prescription drugs, and emergency ambulance services, which we may talk more about. And the others are categories that we could, but do not currently tax.
So this is a summary of the ones that we do collect taxes on, what the rate is and how much money it has raised.
Jen, could that be a little bit bigger?
Good.
Thanks.
And so from the previous slide, Jen had raised that there was inpatient hospital services and outpatient hospital services are two. We lump them together and we just call it the hospital provider tax. That is at a rate of 6% of net patient revenue. That is a federal definition. Jen will talk a little bit more about that, I think. But 6% is the cap, the federal cap for which we can do provider taxes. In 2022, we raised $161.5 million. And in fiscal year 23, we are estimating that we will bring in $184 million in the hospital provider tax. That accounts for 89% of all the provider taxes. Nursing homes is a little bit different. It's done as a per bed, but at the time when it was being negotiated, the administration at the time negotiated with the industry and said, what's the easiest way for us to do this provider tax? And it was determined that a per bed rate was the easiest. But if you translate that, it still comes out to 5.8 or 5.9 or 4. I don't remember what it is, but it's a little bit under 6% of net patient revenue. So you can still do the 6% net patient revenue, but use a different formula as long as it, in theory, does not go over 6% net patient revenue. So that one's done on a per bed basis. It raises $14.6 million a year. Next, we have the home health. As you may recall, there's a proposal from the governor, and then you agreed to it in the House to repeal this particular provider tax for home health. Again, intermediate care facilities, it was 5.9, but we don't have any. Pharmacy, it's a 10-cent script. It raises about $800,000 per year. It's a very small amount. And then finally, we have the ambulance provider tax. That's 3.3% net patient revenue. We estimate it brings in between $999,000 to $1.1 million. This is the most recent of all the provider taxes.
And
Yeah.
the nursing home number doesn't go up because we're not going to add any more beds? Is that the
It hasn't gone up. Yeah, as a matter of fact, as the per beds go down, we lose money. But it's been pretty flat, I think, so I haven't really been following on that one too closely. But I don't think it has increased before, but it hasn't increased anytime recently.
Yeah, we'd have to look back at the legislative history to see when that last change.
Yeah, but it's been relatively consistent.
Well, wait, we're talking about two different things. I think you're saying relatively consistent, meaning the 4,919 or the actual 14.6?
14.6.
Oh, okay, we are talking about the same thing. Okay.
Yeah. But your point is, I get your point, where 6% net patient revenue goes up, the 6% goes up, but as a per bed, it would stay flat. I
Yeah.
understand your point.
I guess the underlying question is, are we adding nursing home beds in the state?
I believe, if anything at all, we are reducing nursing home beds in the state, only because nursing homes have been going down. I don't know that, or nursing homes have been being bought or going out of business, closing. I don't know of an instance where a nursing home has said, I want to add beds, or a new facility has come online.
Really?
Part of it's tied to the move to more home community-based services.
Yeah.
I just had a quick question to make sure I understand the intermediate care facilities. So this slide says the last one closed. And then I think I heard you say, Nolan, that the tax has been repealed. So if no?
The home health tax is being repealed,
I'm so sorry. Okay.
or proposed to be repealed.
Okay. So if a new intermediate care facility were to come to Vermont, they would be taxed at that rate.
Correct.
Thank you.
I think Carol had something, right?
Yeah, I did. Intermediate care facility, and then I almost thought I heard you say continuous care facility.
Nope.
Okay. Did the continuous care facility ever pay taxes, provider taxes?
Don't believe provider taxes, I don't think they really fall within the categories that are permitted. So a portion of their services maybe could if they have, where they have nursing facility services. But I do believe there are tax provisions relating to them in the tax code, but I don't recall what those are.
All right, I'll follow up. I don't know.
But in theory, they're not, as a standalone, not a taxable.
Right, they're not
Entities.
taxable.
To the extent that they provide any of the services that are taxable, they would be taxed, but I don't believe any of them do.
Any of
So who pays the ambulance tax?
Ambulance providers,
So like the rescue squad?
like Rescue Inc.
Yeah,
That's why he's here.
I know, but I'm,
So I can tell you a little bit about the ambulance provider tax. There
Well, do you
are,
want to hold on that until we get through
Okay.
the,
sure.
Because we're going to focus, we're doing big picture and then we're going to go deep on the ambulance.
okay.
Okay. So this is just to give some context. This numbers are old because this is presentations a few months old, but the provider taxes are deposited into the general fund. They previously have been deposited into a separate fund, but now they're going to the general fund. About a third of all funds used, or equivalent of about all funds used to fund Medicaid, about a third of the funds are from provider taxes. Almost 90% of the state funds used to fund Medicaid program are equivalent to what we get in provider taxes. This just gives you a sense of the magnitude of the provider taxes and how that money is, traditionally it used to be it went into a special fund and then that money was used to draw a match, but now it goes to the general fund. So it's sort of fungible. It's like water, it goes into there. So you can't say this dollar is being used for this match, but you could say the equivalent of that amount of general fund that we put into that fund is used to draw down this much Medicaid or relative to the total Medicaid fund. So this is really just meant to give context in terms of the Medicaid, all the funds, and then the state-only funds. So you can see that provider taxes are a big chunk of the money we use, or equivalent to the big chunk of the money we use to draw Medicaid.
Yes.
That'll match.
And I think you already answered this in another context, like the transport match. We generally raise enough to draw down everything we can draw down. the federal.
Well, that gets into the whole global commitment and caps
Okay.
and, you know,
Right, because we've got special deals, that is arrangements.
yeah, we have what's called a global commitment
Right.
waiver. And under that, we are able to draw a match on certain things, but there's a cap. If we go over the cap, it's all, so it's a small piece of a very larger equation.
It's not the same discussion, obviously, of the transport one.
It's a little different.
Yeah.
All right, and so as we have talked about, these provider tax revenues get used as part of this, our state share of Medicaid. That's kind of how they're envisioned in the federal law. But there are, and I know we talked about this when we came in a couple months ago, but just for a reminder, there are certain requirements in the federal law that provider taxes must comply with. They have to be broad-based. So when we look at these classes of healthcare services, they have to apply across the whole class. You can't carve out a segment of one of these classes and just impose the provider tax on one segment. They must be uniformly applied. So there has to be the same percentage tax or the same licensing fee or per bed fee or assessment rate on the gross or net receipts across the whole class. It has to be applied to the whole class. It has to be applied uniformly across that whole class. And I remember talking to you about this, it cannot hold providers harmless. We cannot provide a guarantee in any way, directly or indirectly, that the tax that a provider pays in provider tax will be returned to them through Medicaid funds to make them whole. So we do use the provider tax revenue to draw down federal match, but we cannot make a guarantee to the providers that we will pay them back for the amount of the provider tax that they pay us. There is a safe harbor. So when Nolan was showing you that a lot of the taxes are at or below 6% of net patient revenue or the equivalent, that's because there's a presumption in the federal law that if your provider tax is less than or equal to 6% of net patient revenue, then you are not guaranteed, you are not holding anybody harmless. So if you have a higher percentage than that, you may have to prove that you are not holding providers harmless, but if you keep it at or below 6%, then they will presume that you are not holding providers harmless. So there are winners and losers with the provider tax, depending on a provider's share of Medicaid patients. They may pay in more in provider tax than they get back through Medicaid rates reimbursement for services they provide, or they may end up getting reimbursed more than the amount that they paid in. It really depends on their payer mix.
I just had a flashback from 7 years ago when we did with the home health, and I had a sheet that showed how much each home health provider was paying and how much they were getting back in reimbursement. So anyway, had a flashback with you.
We have that for.
No, this was a work that we were doing on a specific bill eons ago. So no,
Would it be possible
for what?
to understand
I think,
ambulance who's paying in the
oh,
back?
that's a lot of work.
Okay.
But actually, that's sort of the next thing that I was,
Do you want to talk about ambulance next, or you want to talk about language next? Which preference?
let's talk about ambulance next.
Okay.
And stay tuned.
Yes,
Something
and I'm not something to pull up. I just have a couple of talking
Can you
points.
understand?
So the reason why it would be hard is that there are 72 providers for which we collect. And I'd have to go to DEVA and say, can you tell me how much each of those individual providers receives in Medicaid? And then I have to calculate what they're, so it can be done, but it's a lot of work. What's interesting is that we collect the tax from 72 different providers. In fiscal year 23, some paid as low as $138 for the year, and some paid as high as $98,000 for the year. So it ranged. We estimate, the hospital provider tax was actually created, it's the newest of all of our provider taxes. It went into effect in 2015, or was created in 2015, probably didn't start till 2016. The assessment, as I mentioned, is 3.3% of net patient revenue for services delivered to patients in Vermont, so specific to patients in Vermont during the most recent annual fiscal year period. So usually it's a look back of a whole year period. And for the revenues specific to the Vermont residents. Like I said before, we collect about 900. This year, I think we're expecting about $990,000. Next year, we're expecting about 1.1 million raised. So those are my brief facts about the EMS provider tax. I don't know if you have more questions about it.
Confirm what you said, so the 90 or 1.1 million is across all the provider taxes that we tax.
This is just specific to the EMS provider tax.
Here and there in various categories.
No, this is specific to the EMS providers.
Oh, to the EMS providers, okay, good.
Yes.
Thank you.
Jen, can you share the,
That's a lot.
Right, so here is some potential provider tax related language. So it would do two things. One is that it would potentially, or if you went somewhere with this language, it would repeal the ambulance agency provider tax. They're all called assessments in the statutes, but it's what we call a provider tax. This would repeal it on July 1st of 2025. Or a different day. I don't remember if there was a reason we picked that date. And then the second would direct the Agency of Human Services on or before January 15th of 2024 to report to this committee, the Healthcare Committee, and the Senate counterparts regarding healthcare related tax issues, including the types of healthcare related taxes allowed under, and this is the federal citation, but it's that chart we looked at that had all the 19 different classes. So the types of those healthcare related taxes that we're allowed to collect that Vermont does not currently levy, which other states levy each of the healthcare related taxes identified in that on that list. And for each of those healthcare related taxes that are on the list, the amount of estimated revenue that would be generated if Vermont enacted the tax at various rates, all of which must be at or below that safe harbor threshold at 6%. So how much would be generated if we enacted a tax in each of those provider classes that we don't currently at different rates, all at or below 6%? An analysis of the Vermont providers who would be subject to the tax, mechanisms for collecting the tax, and any other policy and implementation considerations in imposing the tax. And this would appropriate some amount of money, we started with 100,000, to the Agency of Human Services in FY24 for that report. With the expectation they may need to hire some assistance.
can you two tell the story of the old report and the journey we've been on?
Sure. So, in yes, I have the actual prop. So in January 2012, it was done, DEVA commissioned it. It was done by a group called Pacific Health Policy Group. And I think I might have the last two physical copies in existence. And it's at the time, the legislation I think was quite vague. And I think DEVA went above and beyond and just created this lovely document that talks about provider tax, the federal rules, the state rules, who we tax, what each of the provider taxes look like, what states do with the other provider tax, how much money would be raised by the other provider taxes, anything you'd ever want to know about provider tax they did in this study. And
you told me that you still use this binder constantly.
I do. I use it a little bit less and less each year because it becomes less and less valid. But there's still nuggets of joy to be found within the pages of this binder. And also in the legislation that required the executive branch to come up with methodologies, etc. Jen's gonna pull it up. And long story short, in our searches, we were like, are they even still doing that? And we were not able to find anyone in the administration who even remembered the study, let alone doing the work that was required by that legislation at that time.
And like really tried to find people who remembered.
The only two people that remember are sitting in these seats.
Yeah, so
Do you
here,
remember the study, Jen?
I remember that there was a study.
so here's the language from the 2011 Act. It's a little vague. It says, the Secretary of Administration shall develop systems to identify and collect the data necessary to administer any healthcare related tax under that federal part that is permitted by federal law, but that Vermont does not currently levy, including an analysis of the base to which such a tax would apply and mechanisms for collection. So it was a little unclear whether developing systems to identify and collect the data necessary to administer these taxes means they were supposed to create something that could be sort of continuously or through repetition queried and spit out results, or I think the way it was interpreted was write a report.
The other thing one thing that did come out of that report was a couple of years later, the Shumlin administration proposed implementing a tax on dentists. And in this report, it also talks about like the pitfalls. And one of the things that came out of it was that where with like nursing homes and hospitals, they have a lot of reporting requirements already. So to the state, so we know what they're earning and net patient revenue. It's not that hard. With dentists, like they don't have audited financial statements, they're private businesses. And so there was no way to get at what their net patient revenue, we didn't know how many dentists there were. It became a real problem for how would you actually come up with that. So that's one of the sort of cautionary tales of we've got 19 provider classes, but they're not all super easy. When the EMS provider tax came along, at the time, we were at a time of tighter fiscal belts. And the EMS providers were really struggling. And so there was conversations with them at the time saying, well, one way we can help get your rates, there's no money around. But one way we can do this is if we do a provider tax on the EMS providers, we can use that money to draw match and increase your rates across the board in a non-uniform way. And so it worked with the 72 EMS providers because we worked with Drew and the association to make it happen. The way you make it happen is if you find a group of providers that's on board with it. If you find a group of providers like the dentists that are not on board with it, it becomes a lot harder. Drew can talk a little bit more about the experience of what I thought would happen and what actually happened, but I'll defer to him.
I think an interesting piece of this is it seems like to me, and please correct me if I'm wrong, that essentially because of those sort of data systems that were in place or not in place, we're essentially taxing providers that mostly bill with Medicaid, and we're not taxing providers that don't mostly bill with Medicaid. And that strikes me as like a fairly funny, non-progressive provider tax in the end. And I understand it was because of this like magical promise of matching Medicaid dollars.
It was like, they used to use the term grow your own.
Yeah.
That was the term that they used back in the day. But yes.
Can I just, this is taking us left field a little bit, but I was noting there was a report due on January 15th, and maybe we would like to change that to December 15th of the prior year.
Jen, I'm on a mission to have all reports due December 15th, not January 15th.
Okay, probably get.
That's why we had a whole thing in a bill, so I could explain.
Me, if I'm not writing the report, I don't need the extra month, but you might, I mean.
The idea is that, so like, part of it's just so people don't work over. Like, in my short time here, I've seen a lot of folks working like over the Christmas break while they should be resting to get ready for the session.
Yes, I think, you may want to hear from the agency generally. I'm not sure.
Yes.
This amount, either whether it's December or January, it may not be enough time.
It might need another 6 months than that.
Right, they may need some
Absolutely.
period longer than that, but it's certainly, I'm fine with whatever date you choose.
Yes.
Is this funding meant to cover all ambulance services throughout the state of Vermont?
So,
What do you mean by cover?
Pay for, whatever we were going to do with some,
no.
are we doing it with everyone?
At the time, it was a way, we were paying for ambulance services prior to that. At the time, it was a way to fund increases to the providers at the time. So we fund ambulances through the general fund. We fund all the other non-taxed agencies or through the general fund as well. So provider tax isn't necessarily a direct funding for the EMS providers. We would fund them anyway. At the time, it was a way to find a revenue source to increase their rates.
That was not correctly done. But what I'm trying to get at is, I thought that, sometimes when you call for an ambulance, your local fire department shows up. And then I thought that was locally paid for. And I think I need to understand.
Yeah, I'm gonna phone a friend on that, or let him answer the question if he were to testify in several minutes.
All right.
Any other questions for this dynamic duo? Okay, thank you so much. Mr. Suskin, I think we're running about 30 minutes late.
Okay,
Is that gonna work for you?
I'll make it work for me. Easy.
Okay.
Yes.
Come back. You are welcome to sit there. You're also welcome to wander the halls and enjoy the beautiful State House.
I think I'll take in the flavor of your work for a while.
Great. You are very welcome.
Come and go.
Okay. Drew, I loved that question that started us off, but let's go back to start at the beginning. Thanks for joining us.
Thank you. So Drew Hazelton with Rescue Inc. I also work with the Ambulance Association and the Vermont EMS Advisory Committee. So I didn't prepare any remarks. So I guess I can kind of answer some of the questions I've heard go around, starting with kind of the EMS in Vermont, which is unique. Like many things in Vermont, it's delivered in a different way in every single community in the state. And in some places of Vermont, you do have municipal services model where a fire department will provide EMS services. That's about 8 out of the 78 ambulance services in Vermont. In a lot of areas, you have nonprofit ambulance service providers that are working in the communities. And there's a few places where you have third-party municipal services where it's a standalone ambulance that's run by a municipality. We do have 2 for-profit ambulance services in Vermont. But that's only part of our EMS system. That is the kind of the transport component. We also have first responders in most of our local communities that come out and actually provide that first level of care, the life-saving treatment before the ambulance arrives. The provider tax was something that we worked on a long time ago now. And it came from desperation. The Medicaid rates for EMS had not changed at that point in almost 20 years. EMS providers were struggling. They're continuing to struggle. We worked with the legislature trying to come up with ways to bring additional revenue into EMS to help stabilize. And the provider tax at the time seemed to be the only path forward. Some of the challenges that exist with it is because it is net patient revenue for patients that are transported in Vermont is not equitable across the state. So ambulance service providers that work on the border, so for example, down in the White River Junction area and transport all of their patients out of state, pay no provider tax because those patients leave Vermont and they're excluded from the tax. So Vermont being a small state with a lot of borders, the assessment around the state is certainly not equitable. And we hear a lot from the leadership of ambulance services about kind of how equitable the provider tax is. We also heard a little bit about the challenges in generating data for dentists. EMS providers in many of our communities are volunteers. They don't have the administrative capacity to put this data together, and it's a struggle every year just to do the reporting necessary to pay their provider tax. How accurate those numbers are, I would say it's questionable at best based on what we've seen for the kind of the capacity of our EMS services to deliver that data.
What do providers tell you about the provider tax?
Repealing the provider tax is usually the #1 discussion every year when we talk about legislative conversations. One of the challenges is the concept of a provider tax is complicated to wrap your head around. And we've had a lot of leadership change in Vermont since the tax was put in. And many of the providers now don't associate the increase in rates they received 10 years ago with the tax they're paying today. So it feels like they got nothing for their tax because the rate increase was 10 years ago.
I wasn't aware, forgot that Mark Valley Ambulance says for the most part doesn't pay. So it all seems perfectly fair. I mean, fair's fair, really, when you get down to it, so.
Yep.
Thank you.
So.
Yeah.
The tax, and then there's the assessment.
Well, they're the same thing.
Same thing.
So it's.
That's your tax.
Yeah, the assessment is the tax. I guess the appropriate phrase is assessment, right?
Assessment is what's used in the statute, I'll call it.
Right, yeah.
Someone else, yeah.
Just want to say, not surprised to hear the capacity across, especially our small communities, is a constant challenge for trying to do things, and it limits access to resources. Do you want to talk a little bit maybe about, I'm curious whether the kind of inequities of who bills for what, how that maybe like plays out as someone who's, led the EMS advisory group and deals with all the different ambulance services. Does that
Yeah, so the inequity starts with not being able to tax everybody across the board. So there are areas of the state that have ambulance service providers that are from out of state that cover their areas. So they benefit from the increased Medicaid rates, but they don't pay into the system at all.
Like New Hampshire, for instance.
For example, New Hampshire services that come into Vermont and so they're benefiting from the tax dollars that we're putting in as Vermont providers in order to get those rates up. And then the really kind of challenging thing about EMS is the structure of EMS. In a lot of our communities, these are 100% volunteer services, volunteer boards. They don't have the annual audit. They don't have the cost reporting like hospitals do. So the work to come up with a number that comes from net patient revenue is difficult. So, that we're just asking more from them every year with more reporting, more requirements. So we have kind of the inequity of the way that it's applied across the state, and then simply the additional workforce burden on people that are already struggling.
Does that make it hard to sort of feel like everyone's on the same team working to kind of cover Vermont if it's like, boy, we have a different burden than someone else, our neighboring service? And
so it hasn't got to the point of pitting one service against another.
Okay.
Because we simply, accept it for what it is. But there's certainly plenty of conversations about you don't pay the same share that I pay into it. And that's recognized across, the services in Vermont that like in our area down in Brattleboro, because we take patients to Dartmouth and to Bay State and to Boston a lot versus in the Rutland area where all of their patients for the most part stay in Vermont by going to UVM, they pay a much higher share of provider tax than we do on every call. So it's more of a burden to them just because of their location. And that's certainly recognized around the state.
Yeah.
Two questions. I was around in local government in Barry City before we had a fairly good and complete accounting system to track our trips and the cost and what treatments were rendered, et cetera. In the early days, it was pretty obvious that it was worth the investment for us to begin to have an accurate evaluation. And I guess I want to ask, since this involves the lack of being able to collect the provider tax, is it, in your judgment, worth the state investing in some sort of electronic or otherwise to complete, if you like, in volunteer-run services? Is the payback there? That is to say, if you can actually reduce the unbilled ratio enough, do you think there's a payback in terms of the provider tax that would be collected?
So I think I understand your question. So Vermont has a state-funded and state-operated EMS data reporting system, which is Siren in Vermont. It's a product by ImageTrend. I've got to be honest, that's one of the biggest challenges in getting reimbursed is getting the appropriate data back out of the state system so that you can bill the calls appropriately. So Vermont kind of got into that with this mandatory reporting, and we still struggle with kind of getting clean reports out so that we can bill back to the.
Can bill. And I guess the second part, I'm surprised to hear that when you carry, just because you crossed the border, you're disallowed. That surprises me. Is that a federal limitation, or where does that come from?
That was in the definition. I don't know how. Oh, when the patients leave the state, that was in the definition. I don't know where it came from and whether it was a state rule or a federal rule.
I have to look at whether, I'm not sure we get tax services provided outside of the state.
I think that's kind of where, because originally it was all calls, and then before it got done, they said you had to exclude anything that left Vermont. And I think that was wise because it was services were outside of Vermont.
Representative?
Well, I'm thinking if it's not a federal rule, then we could say the tax services originating in Vermont.
I'd have to look.
All right.
Anyone else?
Do any of your calls get transported to the state, or they pretty much all go out of state? You don't have a hospital in Brattleboro?
Oh, we do.
Hospital in Brattleboro. It's a very nice hospital with a lovely birthing center.
Okay.
Great
I didn't realize
doctors.
that. I was just,
Yes. We have an emergency room.
Okay. but oftentimes
surgeries.
you're bringing people to Bay State, to Springfield, or to Dartmouth, or I'd imagine maybe Cheshire sometimes, or
Yeah, so
Dickinson, or where else?
exactly. So one of the challenges in Vermont is we have a lot of critical access, a lot of small community hospitals. And those services that are available at those hospitals don't necessarily meet the needs of our patients. So for example, patients with cardiac conditions or in need of surgery need to be taken to a level 1 facility. And in our area, that's Bay State. I mean, this year, Dartmouth, Bay State have been struggling. So we're going to Southern Connecticut a lot, Albany, Bangor, Rochester, New York.
Wow. Rochester, New York?
Yeah. Closest available hospital beds.
5 hours.
Our system of care is collapsing.
Yeah, no, I
EMS is in trouble.
don't know if there's a hospital in Brattleboro.
And
It's a very nice hospital.
since, I'll take one more minute of your time.
Please.
The challenging components when we talk about Medicare reimbursement rates is the rates that we are getting, even with a provider tax, still do not cover the cost of delivering these services. So when we take a patient, for example, from Brattleboro Hospital to Portland, Maine, because that's the only available bed, the cost associated with that to deliver that service is huge.
Yeah.
The reimbursement doesn't change for us because EMS is paid like Uber. Unfortunately, we don't get paid for medical treatment. We don't get paid for medications. We don't get paid for the clinical expertise. We get paid by the mile like a taxi or an Uber does.
You get paid more when it's a busier time. I'm just kidding. Sorry.
Unfortunately, we don't.
I couldn't help it.
And
You don't
so as our system is becoming more and more stressed and we have to go further and further away, the cost of that burden is landing directly on the providers, not the system.
And do you also, you've told me before that you also respond to calls that then don't involve any transportation for, as other systems get more and more stressed and you're sort of the call of last resort for a lot of folks. You're more often the call of last resort.
So EMS is the universal healthcare. Every time you call 911, someone will come to your aid. And if you are a person that has been trying to get a doctor's appointment and can't get your doctor, can't get to the emergency room, when everything else fails, 911 is where you go. 20% plus or minus, depending on where you go around the state, 20% of the time, that does not generate a transport. And in our world, we get paid based on transportation. So we're already subsidizing the Medicaid system by providing these services that we can't really bill for.
Nolan, you want to jump in?
Yeah, I just want to remind the good news is that the House passed budget does propose increases for EMS rates. So I wanted to just make sure that, remind the committee that there is stuff in there. On there.
And we'll see if our study makes it across the finish line too to help get a handle on the whole system. Can you also just talk a little bit more about, so I hear you talking about how it is not always adequately reimbursed transportation from hospital to hospital. Can you talk about the life and death impacts that sometimes has on people who are waiting in hospitals?
Yeah, so again, as hospitals are struggling, ambulance services are going further. It means the longer it takes for ambulances to go out, transport those patients and come back. That's one factor we have. We also are struggling to maintain our workforce. So as our workforce is declining, it is also limiting our ability to help get patients to where they need to go. There are cases, and there are certainly hospitals, where patients that are needing critical life-saving surgeries are waiting 10, 12, 17 hours for ambulance transport because there simply are no ambulances available. That's not isolated to any one hospital in one area. It's a systemic problem. Part of that is due to years of underfunding and support for the system. So we don't have the resiliency that we should. Part of that is simply fatigue from 3 years of fighting our way through a pandemic. EMS got through this pandemic with just brute force, working, day in, day out. Many people spending weeks at a time taking care of COVID positive patients to get through the pandemic. And I'm certainly not faulting anybody that opted to retire after the pandemic. Many of our EMS providers started in Vermont when EMS was kind of created in the late 1960s. And they're at an age where their concern for their health during the pandemic was real. And we lost almost 30% of our workforce due to that. So it is definitely a struggle.
Kurt, did you? No, okay, great. Peter.
I'm dumbstruck to hear that it's only mileage. In my immediate area, we have several providers who have gone the extra advanced life support as opposed to simply basic beds in a truck. And to think that there's no recognition of that, either training or investment, is astonishing. I don't know why. I know we bill insurance companies depending on what we provide, but I'm astonished to hear that the basic Medicaid coverage for people who are judgment proof, as it were, can't pay, is either mileage or nothing.
Yes, it's a small base and then you get a mileage.
And
incredible.
Yeah, and that's not something that we can necessarily work on in this room. What we can work on in this room is the provider tax, which is already fairly inconsistently pulled on. So hoping we can do that. Yes, final question. And then we're going to talk about the Shelburne charter change because our next witness has come.
But I heard you say there were several kinds of models that across the state. And this might not be something for us, but if we had one model and said, if you use this model, this will be how we pay you for mileage, this will be how we pay you for reimbursement of medical services provided and so forth. It's your decision whether or not you want to do that model, but that's the way you're going to get something or something like what we're going to provide for you. Then what would your reaction be to that?
I am excited for the possibility of creative solutions because we are on a collision course with disaster when it comes to EMS. Unfortunately, the vast majority of our funding comes from the federal government, and we're kind of bound by the way Medicare will allow us to operate. So, from an EMS perspective, when you call an ambulance, the only place we're allowed to take you is the emergency department. That may not be the right choice for you, but those are the rules we have to play by. And unfortunately, most of that is not really within our control.
So maybe we could even ask for a waiver, different thing. But anyway, yes.
Pretty far off the tax base here. Is there anything anyone else would want to hear next week on provider tax and Jen's, on the language that Jen shared with us?
somebody else had their hand up. I would kind of want to know the amount that we really need. Like, when we looked at the childcare, it was, this is the level of care, and this is the cost, according to the RAND report. I'd like to know what we really need so we can raise the taxes.
So there's a
fund it.
study that is in the House budget, and there's another study for provider taxes in Jen's language. And that's why the sunset is out a couple of years, so that we'll have time to understand things before we make decisions, but clearly communicating that we are on our path towards a decision. But I guess, I mean, we need to wrap
Can we increase
up.
the tax before we get the results of the study, or no?
It's a,
Just to
No.
start helping people, all right.
but we can't wrap it up today, and we're not gonna wrap it up today. We have another witness. I'm just wondering if anyone wants to hear from anyone else.
Jen's just is.
Jen's,
Permanent or Diva to come in.
yes, and tell us if that study will work. Thank you. Yep. Okay, great. Thank you. Okay. Thanks for remembering that. Okay, great. Thank you so much, Drew.
Thank you very much.
And I will just add, it does look like the requirement that the services be provided in the state is from the federal.
Okay, thanks. Okay. Tucker will be back here in just a moment. But I think we could, what?
Okay.
Okay, I think we could probably hear from Mr. Susskind. Is like he right? Is like right gonna be here?
We taking a break or
We're just waiting a moment for Tucker.
Be at ease.
We're at ease, but we're still live, so we're not, you know.
Can I ask you a policy question?
Absolutely, that's a great
Since we're
time
live?
thing to do, yes.
If we wanted to raise a tax, the provider tax, very briefly, while we wait for the study, it seems like it's a long time to wait for the study. If we were to try to help some of these organizations, is that allowed?
So I think, so the language from Jen does two things. It sunsets the EMS provider tax and it calls for the study. I think it's hard to levy, I think it's generally difficult to levy a tax or a fee if we don't know how much we need or what the financial circumstances are of the situation we're levying it from.
Arguably, however,
But there,
just talking, that
Yes.
since it's not a one-to-one, we're not supposed to levy it and put it right back to a particular place.
Mhm.
I'm just thinking, is there some creative way that we could help ease this burden?
well, I think in the short term, we are easing it with general
Right,
fund
not-
dollars and there's more money. There's a big rate increase coming in this year's budget. That's not a one-time rate. There was a rate study that was done and they responded to that rate study in the budget after some good work by the healthcare committee. So I think that's the short-term solution. And then removing the provider tax is the midterm solution. And then maybe there's a long-term solution that will not probably happen here. It'll probably happen
Okay,
somewhere over there.
now I got it.
Okay.
Thank you.
I thought I had understood from.
I'm sorry, 1 second. Mr. Susskind, we're just waiting for legislative counsel to take us through the very short bill before you tell us how much you like it.
Thanks for
Great.
explaining it to me.
Absolutely.
I just thought there were some permitted taxes other than EMS that we had not taken advantage of. And that would be an interesting short list.
Yes, I think
Start.
that is what the study is
Okay.
going to look at.
All right.
Because my understanding in talking to Nolan and Jen about what happened a decade ago, that maybe Jim, you remember some of, is that there were taxes that were identified that were too, just like technologically complicated to levy, even though they might have been better choices for provider taxes. And maybe that's different now. I don't know.
Yeah.
Some that would have been just impractical.
Would have been what?
Impractical.
Yes.
Well, I'm very glad we're doing something about this. Don't you say?
Me too.
Okay, thank you.
So how many minutes do we have? Unknown?
It's unknown minutes, so I would not leave this hallway so that you could see Tucker's return. For instance, I'm gonna get water from the hallway.
That's what I was thinking, but I will not go not out of earshot, as my mom would say.
I heard that.
Or is what your mom said. That's right, that is true.
Yeah.
Lisa
Right there.
used to hang out here.
Yeah, I remember you.
Oh, good to see you.
You too. How are you been? Well enough, it looks like. Well enough, right?
Well enough, and, across the state tournament is for.
Right.
It's great, it's become like this. Well, I'm thinking.
Who's complaining?
Still there.
That's insane. Have you got another one?
Tucker.
Hello,
Thanks for joining us.
my pleasure. Good afternoon, Tucker Anderson, Legislative Counsel.
Will you tell us about the Shelburne charter change?
I absolutely will. You have in front of you H 489. It approves an amendment to the charter of the town of Shelburne to allow the town to adopt a local option tax. Section 1 of the bill expresses the General Assembly's approval of the charter amendment and states that the voters of Shelburne approved the proposal of amendment on March 7th, 2023. There's one amendment to the charter. It has a section 9.3, which expressly allows the select board to levy a 1% tax on sales, meals and alcoholic beverages, and rooms. It provides that any local option tax that is assessed by the select board in town will be administered pursuant to General Law 24 VSA, Section 138, which is the local option tax statute.
Is there anything unusual about this tax?
For chartered local option taxes, there is nothing unusual about this. It is in fact an exact replica of what St. Albans passed a year and a half ago and that the General Assembly enacted for the city of St. Albans last session.
Seeing no questions? Yes.
Do you know what the vote was on?
I did.
We have our next witness. I'm sure he'll be prepared with that piece of information.
And there are no special conditions on this, has to be its use or anything like that. It can be used for anything.
It can be used for anything, yes. Some municipalities do have those special provisions. I just walked through a local option tax with House Government Operations downstairs for the city of Rutland, and they have very specific purposes to which their local option tax can be put, but no restrictions here.
Okay, good. Thanks.
Thank you.
Thanks, Tucker.
Mr. Suskin, thank you for your patience and thanks for joining us.
My pleasure. And those are good questions and I will answer them.
Good.
And if I don't fully answer them, let me know. Okay. For the record, I'm Lee Suskin. I'm a former state court administrator and former chair of Shelburne's Ethics Committee. And I now serve on the town's Finance Committee. I'm here at the request of Representative Brumstead, who has sponsored this bill, and our Select Board Chair, Michael Ashew, to introduce H 489 to you. Thanks for this opportunity to provide you with the information on the town's decision to amend its town charter to authorize the Select Board to levy this 1% tax on meals, on retail sales, meals, alcoholic beverages, and rooms. And we seek enactment of H 489 that you just heard about. I'll take less than 10 minutes to provide the committee with some background on the factors the town considered before adoption, anticipated additional revenue generated, the town's policy on how the additional revenue will be spent, to answer your question, and steps taken to inform all residents and businesses about the local tax in the months leading up to the town meeting day vote. It started in April 2022. The Select Board held a retreat with its theme Shelburne 2035, long-term steps to achieve town goals. Many members of the public participated. The participants learned that we have $60 million plus in capital expenses facing the town in the coming years. At the retreat, the Select Board wondered, what is a local option tax and could that help the town pay for some of those expenses? So they asked the town's Finance Committee to gain an understanding of the tax, explore whether it will aid the town to meet its goals of providing quality municipal services to residents, businesses, and those who visit our community. The Finance Committee accepted the challenge. We learned what members of this Ways and Means Committee know very well. In 1997, the Vermont legislature enacted 24 VSA Section 138, enabling a municipality to assess this 1% tax on retail sales, meals, alcoholic beverages, and rooms. We learned that just as the state exempts many basic necessities from the state sales tax, so will the town exempt them, those necessities will be exempt from the local tax. We learned that the state will administer it and that the local tax will not place any additional burdens on retailers to report sales and submit the tax to the state. We learned the state keeps 30% of these receipts to fund the pilot program, payment in lieu of taxes, along with $5.96 per return fee. And we learned that the local tax will include a 1% tax on Shelburne e-commerce sales and on short-term rentals. We worked with the tax department closely with many of the people who appear before this committee to project Shelburne's annual local option tax revenue, and we projected at approximately $1 million per year. To place that in perspective, Shelburne now collects $9.8 million, 80% of it from the property tax. The rest from fees. The Finance Committee also looked at the visitor tourist activity to the town. Shelburne Farm, Shelburne Museum, Teddy Bear Factory alone attract hundreds of thousands of visitors annually. LOT will enable visitors to the town to help pay for the town's roads, facilities, and services that they use while in Shelburne. We learned 24 of Vermont's municipalities already levy a local option tax, including 6 of our neighboring municipalities around Shelburne: Burlington, Colchester, Williston, South Burlington, et cetera. The Select Board asked the Finance Committee to present what we learned to town residents and businesses, answer questions, and hear their concerns. We did so. We notified local churches, businesses, and restaurants that we could make ourselves available to present information to them and hear concerns from their congregants and employees. We produced informational handouts for distribution at the farmers market. We prepared a slideshow, used it to present information to the Rotary, the Business and Professional Association, and the senior living facilities. After informing and hearing from residents and businesses, we recommend that Select Board amend the charter to authorize the tax. The Select Board held their own public meetings and took their own public comments. In response to those comments and to ease concerns as to how additional revenue would be spent, the Select Board adopted a policy. It's not in statute, but a policy restricting lot revenue to capital expenditures, debt reductions, reserve funds for capital projects, repairs or other emergency needs related to declared disaster, and conserving and protecting open land, i.e. not for operating expenses. The Select Board determined that lot would diversify the community's high reliance on the property tax revenues and decided to place the article on the town ballot at town meeting day in this past March, asking voters to decide whether to adopt an addition to the charter with a language that's in H189. Note that thanks, as the Legislative Council said, thanks to guidance from Representative Brumsted, the Select Board made sure to adopt language the legislature has approved for other municipalities in the past. Voters decided to amend the charter with 57.6% voting to do so. The town needs lot revenue to pay for fire and rescue upgrades, road equipment, bike and pedestrian paths, repairs and installation of our buildings to reduce heating bills and use of fossil fuels, and to pay for capital expenditures that town voters want and have approved in recent years. The town requests your committee to vote yes on H49 so that the town can do so. Any questions?
Does the town of Shelburne share a zip code with any neighboring towns? Because we have a issue sometimes with being able to distinguish if you're in Shelburne or if you're in a neighboring town, if you have the same zip code.
That's a good question. As far as I know, Shelburne is 05482. My guess is that there may be some residences that may be outside of that. And I understand from your chair that the tax department is addressing that issue.
Yeah.
Shelburne, in my talks with Director of Finance there, they worry about that, they take care of that. And Shelburne does not have to do anything to figure out the different zip codes and whether it's assessed. And I guess they will deal with complaints, although I'm sure the select board and the finance committee will hear complaints.
Cool.
But it's in their hands.
Thanks.
And what was you gave the percentage of the vote, but what were the,
The actual vote was 838 residents voted yes, 593 residents voted no, 24 chose not to vote on the article. And this was town meeting, so it wasn't a November election that it would have a greater percentage of people voting, as you all know. But I think so that was about 1,600 voters, which was, I'm on the BCA also, so I think we have about 5,000 on the checkle. That answer that question?
That's what I wanted to know.
Okay.
Right
anyone
on.
else? Anyone have any concerns or conversation points they'd like to share? Yeah.
Just one thing, Representative Maddow speak me to my question.
Okay.
But the other, there's another piece to that too, is that sometimes mail from one town is delivered to other towns. And if there are folks who, if there's mail from the Shelburne post office that's going to an adjacent town, to people in an adjacent town, that's another piece that the tax department will have to work out too.
Again, I'm not an expert on that. I think the tax department could and should address it, and you could ask them about it. And if we were in any way responsible for administering it, I would dig into it. But I think I have to leave it to them.
Just a wrinkle for you to know about, and make sure that you're going into all this with your eyes wide open.
Okay, another complaint we may be hearing about.
I think the reality is that the tax department is, despite their very best efforts, and they do make very good efforts and do a very good job with very fine staff, this is not something that they can always fix perfectly. And it's becoming, as we have more and more local option taxes, I think it becomes greater and greater levels of chaos. And so just wanted to make sure that you all are going in with your eyes wide open.
Thank you. What they do is incredible. I did the research to figure out approximately how much Shelburne would receive so that the voters would know and the select board would know. It's a lot of it because we know retail sales from Shelburne brick and mortar stores. That's pretty easy. And the same with restaurants. But when you start getting into online sales, for various reasons, and they can explain it to you if you care, they can't provide that information to towns who are considering this. Because I think it would be way too much work for them to do if it's not needed, whatever the reason. So anyway, I just give them a lot of credit for what they are doing and trying to figure out, and for providing towns like Shelburne the assistance that they provided. They were very, very extremely helpful.
It's good to hear. Yes.
Is Vermont Teddy Bear in Shelburne or Charlotte?
It's in Shelburne. It's on the Shelburne-Charlotte border.
Oh, okay.
And it's just before the border. Just, beyond that intersection there.
And when is the local option tax going to be effective?
That's up to you. It will be effective July 1 on passage. And my hope is, and we have word from the tax department, we've taken all the steps so that if you enact it and the governor signs it, they'll be able to start collecting the local option tax July 1, and they're notifying retailers, I think, next month that that's likely to happen.
Thank you. Anyone want to make a motion?
Make a motion, Madam Chair, that we vote favorably on, so pull the bill up here again. Page 489.
Second.
Representative Demrow moved that we find H49 favorable. Representative Anthony seconded. Our clerk is catching up because that was a little fast. Any discussion? The clerk could please call the roll.
Right. Andrews, yes. Anthony,
Yes.
Beck,
Yes.
Brannigan,
Yes.
Demrow,
Yes.
Maslin.
Yep.
Matos,
Yes.
Odie,
Yes.
Sims,
Yes.
Taylor,
Yes.
Anfield,
Yes.
Kornheiser.
Yes.
12-0-0.
Yeah, we're all.
Everyone's like,
Thank you.
I won't do it again, people. Thank you. Thank you very much, sir, for joining us.